Welcome to this educational video on superior semicircular canal dehiscence, or SCD. This condition affecting the inner ear can cause a range of unusual and often debilitating symptoms. Join us as we explore the causes, symptoms, diagnosis, and treatment of this fascinating and sometimes puzzling disorder. The exact cause of SSCD isn't always clear, but it fundamentally involves a thinning or complete absence of dehiscence in the bone overlying the superior semicircular canal in the inner ear. This canal is normally surrounded by bone. Several theories exist as to why this dehiscence occurs. Some cases may be congenital, meaning the defect is present at birth due to incomplete bone formation during development. Other cases might develop later in life, possibly due to trauma to the head, chronic increased intracranial pressure, or even accelerated bone thinning related to certain medical conditions. However, in many instances, the precise trigger remains unknown. To understand SSCD, it's crucial to grasp the basics of inner ear function. The inner ear houses the vestibular system, responsible for balance, and the cochlea, responsible for hearing. The semicircular canals are fluid, filled tubes that detect head movements. Normally, the fluid movement stimulates nerve cells, sending signals to the brain. However, when a dehiscence is present, it creates an abnormal third window into the inner ear besides the oval and round windows. This third window alters how sound and pressure are processed. Sound vibrations can now escape through the dehiscence instead of properly stimulating the cochlea, leading to sound sensitivity and conductive hearing loss. Furthermore, pressure changes in the middle ear, or even the brain, can now stimulate the vestibular system directly, causing balance problems. While the exact prevalence of SSCD is difficult to determine, it's considered a relatively rare condition. Many individuals with a small dehiscence may remain asymptomatic for their entire lives, and the condition is often underdiagnosed. Studies suggest it affects approximately 1 to 2% of the population, but only a small fraction of these individuals will experience noticeable symptoms. It affects men and women equally and can present at any age, although symptoms typically manifest in adulthood, often between the ages of 30 and 50. The signs and symptoms of SSCD can be quite varied and often bizarre, which can make diagnosis challenging. Common symptoms include vertigo, particularly triggered by loud noises. This is called Tullio phenomenon. Oscillopsia, a sensation that the world is moving, especially during loud sounds or activities like straining or sneezing. Autophony, hearing one's own internal sounds, such as heartbeat, eye movements, or chewing, unusually loudly. Conductive hearing loss, where sounds seem muffled. Hyperacusis, an increased sensitivity to certain frequencies or pitches. Aural fullness or pressure in the ear. Imbalance or unsteadiness, especially in response to loud noises. Chronic fatigue, anxiety, and difficulty concentrating can result from the chronic nature of the symptoms. Diagnosing SSCD requires a combination of a thorough medical history, physical examination, and specialized audiological and vestibular testing. The audiogram may show a conductive hearing loss pattern, particularly at lower frequencies. Vestibular evoked myogenic potentials, or VMPs, are particularly helpful in confirming the diagnosis. VMPs measure muscle reflex response to sound stimulation. In SSCD, VMPs are often present at lower stimulus intensities than normal. A high-resolution CT scan of the temporal bone is crucial to visualize the dehiscence in the superior semicircular canal. However, it is important to note that not all individuals with radiological evidence of a dehiscence will experience symptoms. SSCD is generally not categorized into specific types beyond the degree of dehiscence and the severity of symptoms. Some classifications may refer to the location and size of the dehiscence, which can influence the choice of surgical repair. However, the primary factor guiding management is the impact of the symptoms on the individual's quality of life. Treatment for SSCD depends on the severity of the symptoms. Mild symptoms may be managed conservatively with lifestyle modifications, such as avoiding loud noises or activities that trigger vertigo. In more severe cases, surgical repair of the dehiscence is often considered. There are two main surgical approaches: plugging the superior semicircular canal, which involves obstructing the canal to eliminate the abnormal third window, or resurfacing the superior semicircular canal, which involves covering the dehiscence with bone cement or bone graft. The choice of surgical approach depends on the location and size of the dehiscence, as well as the surgeon's experience and preference. Post-operative rehabilitation may be necessary to help regain balance and coordination. Currently, there are no specific preventative measures for SSCD, particularly for congenital cases. However, avoiding head trauma may help reduce the risk of developing acquired SSCD. Managing underlying conditions that can contribute to bone thinning may also be beneficial. Educating individuals about the symptoms of SSCD can lead to earlier diagnosis and treatment. The prognosis for SCD is generally good, especially with appropriate treatment. Surgical repair can significantly improve or eliminate symptoms in many individuals. However, like any surgical procedure, there are potential risks, including hearing loss, dizziness, and facial nerve injury. Long-term follow-up is important to monitor for recurrence of symptoms. Recent research focuses on refining surgical techniques, improving diagnostic accuracy, and exploring non-surgical treatment options for individuals who are not candidates for surgery or who prefer a less invasive approach. Research is also underway to better understand the underlying causes of SSCD and identify potential genetic factors that may contribute to its development.